Thank you to the organizers for inviting me to speak this morning on large vessel perforation. I have no disclosures. To manage perforation, several universal initial steps need to be undertaken. A balloon needs to be inflated to occlude the vessel. Next, initial resuscitation must be provided in the way of IV fluids or pressors, etc. Then, simultaneously, essentially, you need to ready your pericardiocentesis kit and actually perform pericardial tap if the patient is in tamponade. And then next, it's important to obtain any additional help, for instance, notifying surgeons for potential surgical bailout or involving extra colleagues as needed. Then, if there's persistent extravasation despite balloon inflation, you get into type-specific management of perforations. For large vessels, basically beyond prolonged balloon inflations, you're looking at the use of covered stents. There may be exceptions, for instance, with complex CTO PCI. If you have a perforation, you might occlude the vessel proximally and then perform a retrograde crossing with reentry and exclude a perforation in that fashion. But otherwise, if your perforation doesn't settle down with the use of a covered stent and ballooning, then you're looking at reversing anticoagulation, especially with your gear out, and potential surgical bailout. It's next important to be familiar with the types of covered stents that are available, because this will influence essentially what you can do and with what guide. Traditionally, it was the Graft Master that was used. This is a notoriously bulky and difficult to deliver device, basically a stent sandwich with a layer of PTFE in between. For this device, you need a 6 French guide just to get the device in on its own, and if you're using a 4.5 millimeter Graft Master and above, you actually need at least a 7 French guide. Now, increasingly, we're using the PK Papyrus, which is a much more deliverable device and is compatible with 5 French guides up to 4 millimeters. Now, if you're using a larger papyrus greater than 4 millimeters in size, you'll need a 6 French guide. Now, it's important to keep in mind that when you have a large vessel perforation, ideally you want to minimize bleeding by often trying to pass your covered stent with a balloon left inflated in the vessel until your stent approaches. And there's 2 ways that you can do that. One is with a single guide, one is with a dual guide or ping pong technique. And which strategy you're able to do depends on what size guide you've already got in there, basically. And it depends on the covered stent you're trying to use. So it's mostly applicable if you're using a Graft Master that you need to look at your guide size. If you've got 8 French already in place, then you can put in a Graft Master that's up to 3.5 millimeters in size with a single guide technique. If you have a larger Graft Master that you need to use, then you're jumping over to a dual guide technique already. Or if you're starting off with less than an 8 French guide in place for a Graft Master, you're going to have to ping pong if you want to leave a balloon inflated in there. If you're using papyrus and you've got more flexibility, and generally, unless you're using quite a large papyrus, you can probably proceed with a single guide as long as you've got 6 French or more in place, which most of us. For the single guide technique, essentially you've got a wire across the lesion, balloon is inflated, you take a second wire, bring it to the balloon, deflate the balloon, get your guide wire across, and then you reinflate the balloon. Then you bring your covered stent in on that second guide wire, deflate the balloon, retract your balloon and your wire, and inflate the covered stent and hopefully achieve hemostasis. When you're using a ping pong technique, essentially you've got your balloon up on your wire, occluding the perforation. Then you back your guide out of the coronary ostium. And now you back a second guide into the coronary ostium with a wire loaded in it with a covered stent on top of that wire. You then deflate the balloon transiently, get your second wire across, and pass the covered stent over that wire, deploy it, and then hopefully achieve hemostasis. I'd now like to talk about a couple of large vessel perforation cases. So first is a 78-year-old female with NSTEMI, a suggestion of high-grade LAD lesions on her CTA. At cath, you can see indeed that's true, and in particular there's this sort of mid to distal LAD lesion through a highly tortuous segment, and if you look in the LAO cranial view, you can see there's almost sort of a 360 loop-to-loop headed down into that more severe area of disease, and of course there's also the proximal lesion to deal with. This patient did have other CAD, and so I actually reviewed the case with the attending physician in terms of looking at CABG versus PCI options, and he encouraged me to proceed with PCI in this case. The patient was of advanced age, had some comorbidities. Despite the complexity, they were relatively focal lesions, so I said okay. I wasn't keen to force devices through that tortuous segment, and so I started with simple balloon dilation initially, and a 2.5 millimeter balloon did expand. However, when I deployed a 2.5 millimeter drug-eluting stent, unfortunately there was a significant waste. I did further post-dilate the distal stent with a 2.75 millimeter balloon, and I placed my proximal stent. I then retracted my wire and gave nitroglycerin to evaluate the mid-segment because I felt there was an element of pseudostenosis at play. However, it looked persistently poor, so I decided to place a third stent in the mid-segment. A 3 millimeter DES was deployed, and I inflated the balloon across the overlap, and then I advanced it a bit more distally and inflated very gently to see if I could further expand that underexpanded segment in the distal stent. The stent did expand, but unfortunately I took a quick puff and I could see that there was a large perforation, so I inflated my balloon immediately, but despite that the patient became hypotensive, altered level of consciousness, required brief resuscitation. We readied the pericardiocentesis kit, called for stat echo and additional help. You can see that I had a balloon up here occluding the vessel, and we promptly performed pericardiocentesis, which luckily led to significant improvement in the patient's status. Next, after prolonged inflation, I did a test to see if there was ongoing extravasation, and you can see there's a significant perf still happening there. So at that point, I deployed a papyrus 3 millimeter covered stent. Unfortunately, when I pulled the balloon back to take a look, you can see that this actually induced a second large perforation more proximally. So therefore, I deployed a second papyrus 3 millimeter in the mid-vessel, and luckily this achieved hemostasis. The patient was discharged in stable condition a few days later for medical therapy of her residual CAD at her preference. The second case is an 87-year-old gentleman who's actually still practicing family medicine. He was referred due to increasing exertional dyspnea with moderate to severe MR on echo and was sent for right and left heart cath. So there was no suggestion of severe MR at cath, and I reviewed the patient's case further with his referring physician who was in-house. I had found these significant lesions in the right coronary artery, and after some discussion, he recommended that I proceed with intervention in hopes that this might improve the patient's symptoms or possibly even improve his MR as well. I pre-dilated the lesions with 2.5 and 3 millimeter balloons and then deployed a 3 millimeter stent distally, which expanded as you see here. I then deployed a 3.5 millimeter stent proximally, which expanded, but was followed with a brief episode of hypotension and chest pain. Quickly recognized a perforation and inflated my balloon. I don't have an initial picture. The patient responded quite well to initial resuscitation. There was only a trivial effusion on echo, and I deflated the balloon after some time, and you can see there's still persistent extravasation. I did deploy a 3.5 millimeter papyrus stent in the proximal vessel. There was still ongoing bleeding, and formed prolonged balloon inflations and post-dilation, ultimately achieved hemostasis and a reasonable final result. Thank you very much.